Good evening and welcome to the latest in a series of webinars from the MDU on various medical legal topics. My name is Ed Farnan and I'm one of the medical legal advisors at the MDU. I'm joined this evening by two of my colleagues from the advisory department, Dr. Sam Bell and Dr. Nikki Leonard. And while I am presenting a short presentation this evening on tonight's topic, which is the new GMC guidance on prescribing, Sam and Nikki will be working in the background fielding your questions. You can enter those questions using the chat box on the webinar software. What we will do is that Nikki and Sam will collate those and we will have a discussion on the sort of the most common questions that are coming to us this evening at the end of the presentation. If I will then make myself invisible and start the presentation. So tonight we're going to talk about, as I say, the recently published GMC prescribing guidance. This was published about 6 weeks ago and it updates the guidance which the GMC previously published about 8 years previously. We can't go through all of it individually this evening, through every part of it, but what we hope to do is to identify what's changed, to some extent what's not changed, and in particular, because of the climate that we're currently working in, perhaps to focus on some of the issues particularly arising from remote prescribing. If you're familiar with the old guidance and if you hadn't had a chance to look at the new guidance yet, you'll be possibly reassured that much of it is very similar, but there are some things which are different, which we'll try and tease out tonight. The GMC's guidance, like all of their publications, is available on their website, and I would certainly recommend that you do review that when you get a chance. It's not overly lengthy. It highlights a number of important points, some of which are, I think, fairly self-evident, but others perhaps are worth knowing if they haven't previously occurred to you. We're going to start with a number of polls, or we're going to have a few polls throughout the talk this evening, mostly focusing on remote consulting. And the question firstly is, do you feel confident in prescribing remotely? And you can enter your answers to that on the webinar software. So I'll give you a moment just while we gather that. I should say, while you're filling in the poll, that certificates of attendance will be emailed out to you later this week or early next week. And the webinar will be available on our website, as are all of our webinars, if you have to leave this one early or if you join late. So we've got a good number of responses there. We can probably stop the poll. In answer to the question, do you feel confident in prescribing remotely? About 55% of you who answered said yes, that you do feel confident. 18% no, and 27% perhaps not so sure. So hopefully that at the end of this presentation, if anything, you'll feel slightly more confident about that. I think the first thing to sort of touch on, if we're going to be talking about prescribing, is to see what we mean when we say prescribing. And the GMC has included this type of information in its guidance. Self-evidently, when we talk about prescribing, we mean supplying prescription-only medication, whether that be in hospital practice or in the community. But the GMC has gone beyond that and says that this guidance also applies to prescribing medicines, devices, dressings and activities which include exercises. So that would include what's becoming increasingly prominent is lifestyle prescribing or social prescribing. It also talks about the guidance applying to advising on the purchase of over-the-counter medications and other remedies, and on the provision of written information and advice to patients. Some of this guidance will apply only to the prescription-only medication, and indeed all of this guidance probably does apply to prescription-only medications, but there are parts of the guidance which will be particularly relevant to other areas of prescribing, so it's useful to be familiar with it in that context. If we move on just to discuss a brief case example, just to show how some things can go wrong with prescribing. This is perhaps a a particularly extreme example, but it illustrates a point which I think could apply to almost any sort of medication. And if you can imagine a patient on a ward or in the community in a GP surgery being seen with severe chest pain and a myocardial infarction is diagnosed. The doctor wanted to administer some diamorphine as pain relief, but rather than giving 10 milligrams as intended, they drew up a 100 milligram amp in error. The patient, not familiar to opiates, had a respiratory arrest, and fortunately there was naloxone available, but after it was administered, it was discovered that this was out of date. The doctor, understandably, was not expecting the 100 milligram amp to be kept where the 10 milligram amps were, but didn't think to check. And this illustrates, I think, what a lot of doctors will be familiar with in terms of significant events, which is the old Swiss cheese model. This slide is a slight variation on that model. The usual model is that the holes have to line up and something has to go wrong at each point for an adverse incident to occur. This slide, I think, reverses that model slightly and shows that if you want to prescribe safely and for all of the steps to be successful and safe for the patient, that all the holes have to line up for a number of significant things to go right, as well as for a number of significant things to go perhaps wrong. And you want them all to go right in order for there to be a safe prescription. And this slide to some extent illustrates what happened in the previous slide, which is that a number of different things potentially had to go wrong. Drugs being kept in the wrong place, things not being checked, things not being up to date, and so on. And as we all know, I suspect the errors which actually go on to cause patient harm may well just be the tip of the iceberg. In addition to those errors which do cause actual harm, there are errors which we identify which had the potential to cause harm but didn't cause actual harm, which is what we call near misses. Errors which are identified but which didn't cause harm and are considered insignificant, but perhaps identify a potential problem which had the chances of something worse happening. There are potential errors, and then there are unnoticed errors which actually did happen. And as I say, the ones which go on to cause actual harm may well just be the tip of the iceberg. What's common in all of these, and I think in all significant events, is that there is often a communication problem which underlies some or all of the issues which give rise to the significant event. And that might be in respect of prescribing, that you prescribed without all of the records being available or with the incorrect records being available to you. You may well have not gone through the appropriate process for obtaining and checking consent before you administered or prescribed a drug. There could be communication difficulties either between primary and secondary care or within your own team, and colleagues and staff, which caused a problem with safe prescribing. There are the administrative errors which can happen so easily with patients with similar names, either two patients registered with your practice or two patients on the same ward, and then transcription of information being done incorrectly or erroneously. And all of those have the potential to cause problems in terms of safe prescribing. We look at drugs which are commonly cited in claims, and this is an old MDU study, and I think these are still valid. And also these are drugs which potentially give rise to significant events, to GMC investigations, and also to complaints at a local level. And it's not surprising that these are drugs which crop up frequently because they're drugs which are prescribed frequently. Everybody knows about the frequency of prescribing of antibiotics, oral contraceptives and the like. And steroids are drugs which are prescribed widely across many different specialties, but they are also drugs which have the potential to cause harm. Steroids may be prescribed for something like, for example, giant cell arteritis. And if the drugs are prescribed at a high dose initially, and if the patient falls through the loop of follow-up, those drugs might not be titrated down, and then the patient can develop steroid-related side effects. Non-steroidals are well known for causing problems with GI bleeding, with kidney problems. Anticoagulants can cause problems whether they are over-prescribed or under-prescribed in terms of the dose for the individual patient. And obviously one of the issues there in particular is prescribing in patients who are on other medication or patients who have significant comorbidities. Antibiotics, the clear example there is an antibiotic which is prescribed for a patient who is allergic and either the allergy was not asked about or was overlooked. So if we look at the GMC guidance, this is not from the new GMC guidance. This is from their core publication, Good Medical Practice, which is now 8 years old. And one of the very first paragraphs in that is that you must recognize and work within the limits of your competence. And that applies to all aspects of clinical practice, but not least prescribing. And we'll touch on that in more detail later. It also says that if you are going to prescribe drugs for a patient, you must ensure that you have adequate knowledge of the patient's needs and their health, that you provide evidence-based care where possible, and that you also check there are no other medications or problems which might be relevant in terms of the drug that you are going to prescribe. Moving on to the guidance which was published about 6 weeks ago, this emphasizes that the GMC regards you as being responsible for the prescription that you sign, and we'll touch on that to some extent in more detail later. And that applies not only to prescription-only medications, but also to over-the-counter medications that you provide advice about, and other advice that you give, including what we talk about as being information prescriptions, the written advice you give to patients. It talks about things that you can do to try and ensure patient safety, which include things like making use of the BNF, medicines compendiums, which set out the summaries of product characteristics, information from the Medicines and Healthcare Regulatory Agency, drug safety updates and the NHS Central Alerting System, and of course NICE guidelines, all of which contain information which can enhance safe prescribing. It talks about using other colleagues to try and ensure that you are prescribing safely. So for example, senior colleagues or colleagues within your own team, but also elsewhere, or colleagues that you might find elsewhere, such as clinical pharmacologists or pharmacists who might be available to you on the ward or within your own practice. And they may well have particular expertise in medicines management and prescribing issues, which you can fall back on. One thing which is interesting in the GMC guidance is that it suggests that doctors should consider including the clinical indication for a prescription when they prescribe. And this will, to some extent, help the pharmacist or the dispenser understand the purpose of the prescription that you've provided, and they may therefore be likely to spot errors if, for example, you've picked the wrong drug name from a pick list in error. And that's another safety mechanism which might be worth thinking about. If we move on to our second poll, which is which mode of prescribing do you feel ensures greater patient safety? That might be face-to-face, it might be remote prescribing, or you might feel that they offer the same. So again, I'll give it a few moments just while you answer those. There we have about 80% of folk have responded, and I suspect not surprisingly, but about 2/3 of you think that face-to-face offers the safest option. Just under 2/3, just over 1/3 say they offer about the same level of patient safety, but only 1% say that remote prescribing is the safest. And there may well be very good reasons for that. So just in very general terms, before we go on to some of the more specific issues, the GMC expects that you will talk to the patients about the medication you're prescribing. This might include, for example, what to do in the event of side effects or a recurrence of their condition, how and when to take the medication, and so on. And this is all part of the dialogue and part of obtaining informed consent from your patient so that they understand what drug is proposed and the risks and benefits associated with taking it at the suggested dose for the suggested time period according to their individual circumstances. The GMC, in its consent publication, emphasises the importance of establishing a dialogue with the patient. So it's important to take an adequate history, for example, on allergies, on non-prescription medications that they're taking, if they're taking illicit drugs, and encouraging openness from the patient. We have recently published a webinar on consent, which touches on the new consent guidance from the GMC, which was published at the end of last year. And that consent webinar is still available for viewing on our website if you haven't already seen it. So what we're going to touch on, I suspect, more as the presentation goes on, are the issues which our members come to us when they have queries about. And the first of those is shared care prescribing. And shared care is often used in particular for specialist drugs, which would not normally be prescribed in primary care, which require at least some degree of specialist knowledge or monitoring. And a shared care arrangement allows the specialist to recommend that a particular drug be prescribed and to advise the GP on the monitoring of that drug. Delegating that to the GP means that prescribing and monitoring can be done by the GP, which is convenient for the patient. And a shared care protocol will also usually include advice to the GP about when they should contact the consultant. For example, if bloods start to become abnormal. And it's a system which I think is used a lot in some specialties such as rheumatology and dermatology, for example, but perhaps less so in other specialties. There is a section in the GMC guidance dedicated to shared care prescribing. And it emphasises that shared care prescribing is something which can be done with mutual agreement, but the person signing the prescription, which is often the GP, should be content to do so, and the person making the recommendation, which is often the secondary care doctor, has a responsibility to satisfy themselves that the person signing the prescription will be happy. There are some drugs where this is done fairly routinely, and again, I think of disease-modifying drugs used in rheumatology, but this checking of mutual agreement is particularly relevant perhaps with newer drugs or less commonly prescribed medication. This slide is perhaps aimed more at the consultant side, so it emphasises that if a consultant is asking a GP to prescribe a particular drug, you as the consultant must consider their competence and satisfy yourself that they have sufficient knowledge of the patient and the medicine which you might be able to provide them with. And you should be willing to answer the questions that the GP might put to you. Conversely, for the GPs, if you're not certain about your competence to take responsibility for a patient's continuing care, it's reasonable then to go through that dialogue from the opposite direction and to explore things with the consultant to try and satisfy yourself. And if you can't, if there are particular problems which mean that that wouldn't be appropriate in your view, you should try and make other arrangements for the patient's continuing care. So in other words, it should, where possible, be agreed with the consultant, with the patient and the GP, and the specialists should provide adequate information for the GP. There may well be local arrangements, and I can think, for example, of traffic light systems which exist in some areas, whereby the red drugs are prescribed only by specialists, amber drugs are perhaps suitable for shared care, and green can be prescribed by pretty much anyone within their own competence and expertise. Moving on to unlicensed medicines, and again, this is something which comes up fairly frequently in questions from our members to the advice line and when members write in. GMC describes unlicensed medicines as being medicines that are being used outside of the terms of their UK license, or medicines which don't have a license for use in the UK. And they're medicines which are fairly commonly used in some areas of medicine, such as in pediatrics and psychiatry and in palliative care, but they may also be used perhaps less frequently in other areas of medicine. The GMC says that you should usually prescribe licensed medicines in accordance with the terms of their license, but you may prescribe unlicensed medicines where, on the basis of an assessment of the individual patient, you conclude that for medical reasons it's necessary for you to do so to meet the specific needs of that patient. It says you must ensure that there's enough evidence that the medicine is safe and efficacious, because you will be taking responsibility for the prescribing and monitoring if necessary. It says you should make an accurate record of all prescriptions, and where you're not following common practice, why you prescribed a medication which is off license. You should ensure that you give patients sufficient information so that they can make an informed decision about the prescribing proposal, and this comes back to the issue of fully informed consent. And while some medicines are routinely used outside the license, their own sort of product license, for example, in treating children, there are others where that may not be the case. If you're treating in an emergency situation, or where there's no realistic alternative treatment, and providing information about the unlicensed nature of the drug is likely to cause distress, it may not be practical or necessary to draw attention to that. In other cases where you're prescribing an unlicensed medicine which is supported by authoritative clinical guidance, then it may be sufficient just to describe in general terms why the medicine is not licensed for the proposed use or for that particular patient. But you must always answer questions from patients or their parents or carers about medicines as fully and honestly as you can. If, however, you're prescribing an unlicensed medication where this isn't routine, or if there's a suitably licensed alternative available, you should explain this specifically to the patient and give the reasons why an unlicensed medication is being proposed. If we move on to another poll, in this case, we're going to ask, what are you most concerned about when you're prescribing remotely? And that might be prescribing for people who need additional monitoring. You might be worried about an adverse event, or you might be worried about ensuring that a patient accesses healthcare remotely and safely. And just a reminder that this webinar will be available on our website if you've joined late and if you've missed the start, or if you have to leave early, you can access it there. It'll take a few days before it's uploaded. And again, if you've joined late, we will be sending you out a CPD certificate over the next few days. So again, with about 3/4 of folk having voted, about 36% say that you're most concerned about prescribing for people who need additional monitoring. Similar number, just over that, 37%. The concern is about ensuring that patient is able to access healthcare remotely and safely. And the remainder, just over 1/4, saying that they're concerned about an adverse event. So a much more even split there. So on that note, we've asked a number of questions about remote prescribing. It's one of the things which is included in much more detail for obvious reasons. I think in the new GMC guidance, it's something we've all become much more aware of over the last year or so. We're not going to talk about remote consulting in any huge detail this evening, but again, there is information on our website. We've done a couple of webinars on that. There's other published information there which may be helpful if you're interested. And I'd also flag up that the GMC has got a remote consultation ethical hub, which is available, as well as all of the information which is available from the NHS and from various royal colleges and other professional bodies. I think that the important thing is to say that while COVID has meant that many more consultations are taking place by telephone, by video, or other remote means, it's important for you as a prescriber to ensure that you're in a position to prescribe safely, irrespective of how you're consulting. And if you think that the medium that you're using doesn't allow you to do that, then you should consider using something as an alternative. In other words, moving from telephone to video or video to face-to-face. The reason for this is that the GMC is clear that if you are going to prescribe or treat a patient, you must make and adequate assessments of them, establish a dialogue, and obtain consent through the mode of consultation that you're using. Where different options exist and where it's within your power to agree this, you should agree which mode of consultation is most suitable for the patient. But we would certainly suggest, and certainly from a medico-legal perspective, that you keep an open mind about these issues throughout a consultation. And if you think it's appropriate, and if you think that you can't consult safely by remote means for any reason, you consider reverting to a more traditional method of consultation. This is again taken from the GMC's guidance, and the first point here really applies to prescribing in any context, whether that's remote or otherwise. But again, it's worth emphasizing here in the context of remote consultations that a face-to-face consultation might be more appropriate if, for example, you're unsure about a patient's capacity, if you need to physically examine the patient in a way which might not be possible by phone or by video. You may have a lower threshold for seeing them face-to-face rather than remotely if you're not their usual doctor. And of course, if there are safeguarding concerns or concerns about coercion. And again, these are issues which we go into in much more detail in our remote consultation webinar, which you can see on the website. I've highlighted the second point there really because it's specific to a particular type of prescribing. It was in the old guidance as well, but with an increased reliance on remote consulting, it's perhaps worth re-emphasizing that these types of prescribing can't be done in a remote setting. It does require face-to-face. Again, on this slide, the first point is specifically required by the GMC if you're not the patient's usual prescriber, but it's probably good practice in any case, particularly if you're using a medium with which you and or the patient might be less familiar with. The other points are also applicable in any setting, including a traditional consultation, but are worth taking particular care of, bearing in mind the limitations of the medium that you're using. Because you're not physically in the same room as the patient, the consultation may be limited for one reason or another. So it's important to show that you've allowed for that if possible and that you've taken steps to overcome any limitations. And documenting things like what steps you took to overcome limitations and follow-up and safety netting are all crucial, I think, in this setting. One of the challenges, I think, of consulting remotely is knowing where the patient actually is. And I think with increased familiarity with things like Microsoft Teams and Zoom and Skype over the last year, it's become very easy for patients from other jurisdictions to contact doctors who are in the UK. Now, those might be your usual patients who find themselves stranded perhaps overseas because of local lockdowns or travel restrictions, but there is also the possibility that patients elsewhere could contact you without having been in the UK initially. The GMC's added this particular paragraph in recognition of this. So if you are prescribing for a patient overseas, there are a number of things that you probably do need to consider. One of those is how you and healthcare professionals where the patient happens to be will monitor the condition. In other words, how will you apply the remainder of the prescribing guidance to this specific situation? There are local niceties in terms of product names which might differ from one jurisdiction to another, and in particular you might find that a drug has one name in the UK, another drug has a very similar name to that but is an entirely different drug in another country. You will also have to consider, if you are consulting with patients who are overseas, whether you have adequate insurance or indemnity to cover your practice in that jurisdiction, because it's possible that if something were to go wrong in that country to the patient who you consulted with, they could bring a claim through the courts in that country. And similarly, you might be subject to regulatory oversight in that country, as well as being subject to regulatory oversight by the GMC. I think one of the difficulties is that the law will vary from country to country, so it's not possible to answer specific jurisdictional questions here. But suffice it to say that if you're found to have prescribed contrary to another country's laws, not only will you face a possible sanction in that country, but you may then subsequently be subject to a GMC investigation as well. And as well as the above points, I think it's also important to be aware that if you are prescribing for patients overseas, depending on what your actual practice is, you may be required to follow laws in terms of the guidance for import and export of drugs. So in other words, the pitfalls which I've outlined here are potentially the limitations of the medium and how will you overcome that, such as the need for physical examination, access to records so that you're in a position to make an appropriate assessment of the patient, and access to adequate knowledge of their health. And are you in a position to say that you were satisfied that the medicines which you prescribed did indeed serve the patient's needs? So having done that, we'll open our final poll for the evening. And that is really, do you believe that remote prescribing will continue post-pandemic? So again, with about 3/4 of folk having voted, that's a fairly overwhelming yes to that one. I think 93% say yes, 3% say no, and 4% not sure. I suspect the answer is that remote prescribing will continue in some form post-pandemic. I suspect there are different factors which will drive that. Some of those will come from the profession. I think there may well be political pressure to continue some form of remote prescribing, and obviously some patients will want it. And those different pressures may be to some extent in conflict with each other, and we'll see where we end up. We move on to a slightly different thing which sometimes our members do contact us about. This is a scenario about self-prescribing. So the situation which we describe here is that a doctor was prescribed diclofenac by his own GP for the treatment of severe back pain. Several weeks later, he wrote a private prescription for himself for more of the same, on the basis that it was obviously helping, and also wrote a prescription for diazepam to use as a muscle relaxant on a long flight. The long flight clearly predates the pandemic because none of us are flying anywhere anymore. The pharmacist who he took the prescription to dispensed this medication because it was presented on a perfectly lawful prescription, and the pharmacist didn't express any concern to the doctor. And this is not an unusual type of situation. The drugs may change, but when a doctor presents a prescription for themselves to a pharmacist, the pharmacist will often dispense that medication. The difficulty is that the pharmacist will have their own governance responsibilities even if they dispense the medication, and in this case the pharmacist referred the doctor to the GMC, who in turn wrote to the doctor advising him that they were opening an investigation into his fitness to practice. And at that point the doctor called the MDU. And what underlies this is the GMC's guidance on self-prescribing. This is taken from the new GMC prescribing guidance, but there was similar guidance in their previous 2013 publication, which is clear that wherever possible, you must avoid prescribing for yourself or indeed anyone with whom you have a close personal relationship. They say that if you do find yourself in a position where you have to do this, then you certainly should make a clear record. That should include your relationship to the patient where relevant, and the reason it was determined that you felt it necessary for you to prescribe. And you should also follow the other prescribing guidance in any case. Specifically in respect of controlled drugs, and in this case, the scenario, a controlled drug was prescribed, it has particular requirements, and while you shouldn't be prescribing for yourself in most circumstances, the guidance is even more stringent with regard to controlled drugs. And we've included this scenario really as a brief reminder that having a license to practice medicine brings with it the permission to carry out certain activities, one of which is prescribing prescription-only medications. But the GMC is also clear that these activities are privileges, and doctors who exercise these privileges purely for their own convenience may find themselves subject to criticism. The example we gave here was of somebody prescribing a controlled drug for themselves, amongst other things, but it could equally be somebody who prescribes a salbutamol inhaler for their child, and that equally could find them subject to GMC investigation. So in this case, the doctor with MDU input reviewed the GMC's guidance. They reflected on the concern which was raised. We assisted with a response to the GMC, emphasising that this was a single and isolated incident, and that on reflection the doctor wouldn't do the same again. And in this case, the case was closed by the GMC with no adverse finding, but simply with a letter of advice. So in closing, what I would say is that the GMC's guidance is clear that, as with any other aspect of clinical practice, you should prescribe within the limits of your competence and experience. If you are going to prescribe a particular drug, you should be familiar with the drug. If you're prescribing for a patient, you should be familiar with the patient. Where appropriate, you should work in partnership with colleagues and others involved in the patient's care. And as we've highlighted, there are particular requirements in respect of some aspects of remote consultation. So that brings us to an end of the presentation. What I'll do now is invite Nikki and Sam, who I think have been working away in the background and hopefully collecting a few questions, to join me in answering some of those.
Hi Ed, yeah, thank you for that. There's lots of questions come in, so shall I kick off? There's some really good ones that cover sort of all sorts of the aspects that you've been talking about, but one sort of near the beginning. Someone's asked, who's responsible for a prescription? Is it the doctor who signs or the doctor who does the medication review? I think is a really good point.
It is. I think if I assume that the sequence of events is that somebody does a medication review, and then subsequent to that, that drug was reauthorized, another doctor prints off or signs that prescription. But at the time that the medication review was done, I think it's the doctor who does the medication review. But subsequent to that, if another doctor then signs a prescription for that patient, they assume responsibility for that, because the circumstances may well have changed. If nothing's changed, then that's probably fair enough. But if something has changed in respect to that patient, then it's the responsibility for that doctor to ensure that there's nothing else they need to know about when they sign that prescription.
Yeah.
Probably an element of joint responsibility in there, but I think it's the most recent event is the most important.
Yeah, I would agree with that.
I've got a question, Ed, about prescribing antibiotics just in case a patient needs them when they're going abroad. And is that a reasonable thing to do? And would the doctor be covered medico-legally if an adverse event were to occur outside the UK in relation to those antibiotics?
I think that depends on the circumstances. It's a good legal answer is it depends. From a practical perspective, there will be patients who you will be prescribing perhaps rescue antibiotics for in any case. Those might be patients, for example, with COPD, where a rescue pack of antibiotics is available to them as part of their management plan. It might be, for example, patients with recurrent urinary infections. Again, with proper consideration, you've decided that's an appropriate and safe thing for them to do based on your knowledge of them and their knowledge of their condition. I think other than that, those particular types of circumstance, prescribing antibiotics on a just-in-case basis is problematic because you can't be sure that the patient will take them for the indication that you intended them to have it for. And in those circumstances, I think it's mostly going to be safer for a patient to seek medical care where they happen to be.
Yeah, absolutely. I think there's got to be a sort of clinical indication really for the just in case that you know about and therefore can prescribe appropriately, rather than a cover-all prescription really that you don't really know how it's going to be used. I agree with you on that.
Someone's asked about putting clinical indications on prescriptions and elaborating a little bit about what we mean by that. And then actually someone else has followed on from that, saying about adding clinical indications on prescriptions. What about the issue, or is there an issue about patient confidentiality when they go to the chemist, for example, to collect their prescription? Do you have any thoughts on that?
I think that the second point first, it's a very good question. I think one of the things you can do to overcome that is to explain to the patient when you're adding an indication to the prescription that you're going to do that, explain why that's the case, and explain that the pharmacist will be able to see that. And if they object to that, then I think that objection has to be taken into consideration. You can have a dialogue about why you think it's helpful. The pharmacist is likely to be able to work out in broad terms what the indication is if it's being prescribed appropriately in any case. So there's an understanding within that team that there will be some understanding on the pharmacist's behalf that there will be a degree of knowledge about the patient's health, and it's likely to be of benefit to the patient that the pharmacist has that understanding. In terms of how it's done, I'm not sure there's any particular way that I would say it has to be done. It's to some extent in general practice. I suspect that may well be partially dependent on, for example, the IT systems, which may or may not allow that in different ways. It's not mandatory by any means. It's something which is a suggestion from the GMC rather than something which is required. And I think that local arrangements are probably the best way of dealing with that.
Yeah, I mean, and I guess the other thing to remember is that the pharmacist will have a duty of confidentiality as well. So that's a slightly more, another comment on that. Thank you, Ed.
So we've had questions about, in essence, consenting patients to take medications. And obviously, a lot of medication have lots of different side effects. And although doctors spend quite a bit of time informing them about the common usual side effects, it's impossible to tell patients about every single side effect. How are doctors meant to deal with that difficulty, which is really a logistical difficulty? How can you fit all of this into a 10-minute consultation with a patient?
Yeah, I think that's the key point, is that it's where do you find the time to do this? And I think, you know, the system would break down if you told every patient about every side effect of every drug. But in practical terms, I think the issue about consent, which the GMC emphasizes and which I think is now to some extent enshrined in law, is that you have to judge each individual patient on their own merits, and what an individual patient wants to know should be judged on your knowledge of that patient. And it's not a simple tick box exercise. So you'll certainly tell pretty much every patient about the common side effects. Beyond that, there may be particular things that they need to know about by way, for example, of interactions with different drugs. And then beyond that, I think you have to judge each one on its own merits. Some patients you will want to write things down for in great detail. Some patients you will need to tell them much less information. Some patients are happy to be told, I think, that there is going to be a patient information leaflet with the drug which they can rely on themselves. That will depend very much on your knowledge of the patient, I think.
Yeah, I agree. One of our audience has said that they use Accurix, the messaging system, quite frequently to confirm the instructions they've given about a medication, which seems quite a helpful thing to do. But although they were questioning whether or not, if the patient then said that they hadn't got that message, would the fact that you documented it in the Accurix system still count as evidence that you might have told the patient about it? I think it's always helpful to document what you've done, and the more documentation that you can do, the more helpful it is. It points to you having done something, and it's unusual for doctors to document something having not done it, really. So I think that is a helpful thing to do.
Yeah, I agree.
Yeah. A couple of questions come in about patients who aren't necessarily engaged. So, for example, if they're not engaged with monitoring of their blood pressure and they're on hypertensives or antidepressants, or if they're supposed to have blood tests, you know, what to do? And I think that's it's not that common, but it does crop up, doesn't it? I think that puts the doctor in a very difficult position, doesn't it? How to manage them.
Yeah, I think it does. I think, again, it depends to some extent on the drug in question and the clinical indication in question. There are some drugs that if patients are not complying and engaging with the monitoring process, then it's safer not to prescribe. And I think, for example, of something like, we talked about shared care. If you're prescribing methotrexate for a patient with rheumatoid disease, if they're not complying with the monitoring there, it's likely to be more unsafe for them to continue with that drug than to stop it and then try and get them in to have that discussion with them. Conversely, I think nobody is going to be willing to stop insulin for a type 1 diabetic who's not compliant with monitoring. I think those are two extremes. I think most patients fall some way across that spectrum, and you have to judge each one as it comes.
Yeah, thank you.
Yeah. Another member of our audience points out that the medication reviews are being carried out by various different individuals and professionals these days, with pharmacists and such like doing these reviews. Who's responsible in those circumstances? Who's accountable? Is it the GP or is it the pharmacist that's done the review?
I think everybody is responsible to some extent for their own actions, and the pharmacist, for example, will have their own professional code and professional responsibilities which they have to follow. But if you're the GP who is ultimately responsible for the patient's care, then you have an obligation to ensure that the person you delegate parts of that care to are appropriately qualified and are able to do that task in a way which is safe and appropriate for the patient's care. If they don't do that, and if you have concerns about their ability, then you then have a duty to raise that through the appropriate channels, whether it's within your organisation or elsewhere. But the GMC is quite clear that if you delegate care to somebody else, you have a responsibility for ensuring in the first instance that they can do whatever task that is in a safe way.
Absolutely, yeah.
There's a few questions coming from the audience about shared care. So I'll sort of link them together because they may follow on really. So one member of the audience has said, we as GPs are increasingly being asked to prescribe shared care drugs. And we've had a few from gender clinics where GPs are being asked to prescribe hormonal drugs, which we don't have much knowledge about. So who's responsible legally for the prescription? Can we decline? When is it appropriate to decline? What if you don't agree with what they've recommended? So that's a sort of multiple bits of question, but all linking about shared care and what to do if those sorts of situations arise. Any thoughts?
The questions is specific to gender medications, but I think some of those questions are applicable to other aspects of shared care. And the GMC is helpful in that respect if you're a GP and you're receiving information from colleagues in secondary care, that if you're unsure about things, then probably the best way to deal with that is through some form of dialogue. And one of the advantages, I suspect, of the last year is that we're probably much better at communicating with each other in a remote way. So whether it's by phone, by video, by Zoom meeting, by Teams, I think if you've got information from secondary care that puts you in a position that you're just not comfortable with because you feel you don't have the requisite knowledge or information, then trying to establish that dialogue and seeing if there's some sort of compromise can be reached is probably the best way forward in the first instance. In respect of gender medication, the GMC is quite specific in its guidance on this, and I mentioned earlier the remote consultation ethical hub. If you're not familiar with it, the GMC has got a separate ethical hub specifically for trans healthcare, and a very significant part of that is on prescribing in trans healthcare. It certainly is clear that the GPs have an important part to play in that. That shared care will, in many cases, be both safe and appropriate, provided the GP is receiving advice from a recognised expert in trans healthcare, either from a recognised NHS gender identity clinic, or if it's in the private sector, from somebody who has got requisite experience having worked in one of those clinics. And it's perfectly reasonable, I think, in that setting, if you are approached to prescribe for somebody, to seek those reassurances.
Yeah. A little bit of change on focus. There's a question in relation to hospital medicine and what happens when a consultant asks a junior doctor to prescribe a certain medication. Who then is responsible for that prescription? Certainly in my experience, it's not an uncommon happening that the consultant says, just prescribe this. From my point of view, whilst it is the consultant who is asking for the prescription and they are the senior member of staff, I think even as a junior member of staff, you still have a responsibility to check that that's not something either that the patient's allergic to, or they penicillin allergic, and also that it doesn't interact with any of the other medications that the patient is already prescribed. And if you've got genuine concerns about the safety of that prescription, to question that with the consultant in charge, just to make sure and make them aware of what your concerns are. I don't know if any of you have got anything to add in relation to that.
No, I agree entirely. It comes back to the dual responsibility. There's the responsibility that the consultant has if he's delegating that task to his junior, and he has a responsibility in that sense. But the junior then also has their own professional responsibilities if they become aware of something. And it's important that they might spot something that the consultant hasn't spotted, and they shouldn't proceed if that's the case.
Yeah.
Yeah. Another slight change again here. You mentioned about self-prescribing and the view that, you know, the advice about it. What to do if you become aware that a colleague maybe has been self-prescribing? I suppose that touches on raising concerns, doesn't it? Which is a slightly different tangent. But one of the audience members has asked, you know, what to do if they know of somebody who has, you know, self-prescribed.
Yeah, it's a tricky one. It can put you in a very difficult position, because the chances are it's somebody you know. It may well be somebody, and also possibly a personal relationship with, depending on the circumstances. Unfortunately, the difficulty is once you know something, you can't unknow it, and it may well be that your colleague, potentially your friend, is putting themselves in a very vulnerable position by continuing to do that. They might be doing it entirely innocently of the guidance. They might simply be unaware that there's something they shouldn't be doing. Again, depending on the circumstances, you may want to approach them directly just to explore what they've done, why they've done it, and what they understand about the guidance. Alternatively, if it's a more significant concern, it may well be worth escalating that through the appropriate channels, either within your own organisation or externally. Through, for example, in secondary care, through the clinical or medical director. In primary care, perhaps to the CCG or local board. It's difficult, I think, for partners to investigate other partners, for example, but there should be channels where that can be done.
Yeah, and I'd also say, again, it's something, you know, if you find yourself in that position, you know, do speak to us as your defence organisation, and hopefully we can talk things through and the way to deal with that, because it's a very difficult situation, I think. Yeah, thanks.
Well, there's an interesting question about off-licence prescribing. Do you have to be a specialist to prescribe off-licence?
I don't think that's the case, no. I think, again, it depends to some extent on the prescription. There are some medications which are fairly routinely used off license in various circumstances, and we highlighted, I think, one in particular, which is pediatrics, where many drugs are used off license entirely routinely, because they're simply, because of the ethical issues about doing trials on children. It's simply not ethical to do that, but they've become common practice. So, I mean, I think that situation is a very good example of where you don't need to be a specialist. Junior doctors can routinely prescribe off-license drugs for kids. You might want to be more specialist if you're going even further off-piste, I think.
Yeah, indeed, I agree. And I think there's certain prescriptions where you do, in fact, have to be a specialist in terms of the sort of cannabis-based prescriptions. As, the requirements there are quite strict. So it's variable. It depends what you're prescribing and who for.
I'm just scrolling down the questions again. There's a few more about shared care schemes, and can people opt out if they're not happy or don't understand. I think we've probably talked about that, haven't we? But I think you've covered that already. But I think it's quite an ongoing problem, isn't it, about shared care and prescribing, and what to do, particularly if you have doubts and misgivings about it, or not quite sure. And I guess, again, it's one of those things that can be really helpful to talk to colleagues about and discuss amongst colleagues in practice.
Yeah. There's a few questions about just the difficulties that arise from the sheer quantities of repeat prescriptions that GPs are often asked to sign, and if we've got any tips or advice in relation to that.
No, I don't think we've got any real practical tips. I mean, it's a huge burden on general practice and GPs, I think, to be signing these huge volumes of prescriptions. I'm from a GP background, as is Sam, and I can certainly sympathise with that. I think that's where, to some extent, your medication reviews, which we touched on earlier, do come into play. I think that will provide a significant degree of governance reassurance for GPs who are signing repeat prescriptions, to know that there have been appropriate reviews on a regular basis, whether that's annually or 6 monthly, depending on the medication. I think to some extent that's where, to some extent, the presence of pharmacists within the practice, I think, is likely to be helpful, because they will have more dedicated time to look through these patients on multiple polypharmacy. But it's a real burden on GPs, and I think it's something which I certainly empathise with.
Yeah.
Slightly different. A few people have asked, members of the audience have asked about converting a private prescription to an NHS script. So when maybe a patient has been seen in a private clinic or by a private doctor, and then they come and see their NHS GP and say, can we have this on an FP10? Can they do that? What are the medico-legal aspects to consider there?
I'm not sure that it's a particular problem to transfer that type of care from private to NHS. If it's a medication which you as a GP are comfortable to prescribe, which you think is appropriate, meets the patient's specific needs, the fact that it was started in private secondary care doesn't mean that it can't be continued in primary care on the NHS.
Yeah, I'd agree. It would seem unfair. If the patient needs the medication, they need the medication, and they're entitled to it.
Have we time for one more?
There's a few. I'm just trying to scroll through and see what we haven't covered. We've covered quite a lot. Just staring at the screen. That's why. And we think of a good one to end on. There's been so many good questions, so it's been really, really, really good. I think the only problem Nikki and I have had is probably going through them all. If we haven't answered them, I'm really, really sorry. Can you see a quick one to end on, Nikki? I'm doing my...
I'm just, there seems to be several sort of questions in relation to out-of-hours organisations about the difficulties prescribing there when you don't always have access to the medical records of the patient. They appreciate it's a difficult situation, and you have to take a patient's word for what medications they are taking, but be very thorough in documenting what the patient has told you. Do either of you have any other comments over and above that in relation to that?
Not really, just to endorse that, really, I think. Yeah, but difficult situation, isn't it?
Yeah, no, I agree. Documentation in that situation is everything.
Mm.
I think on that note, thank you both for fielding the questions and sharing your thoughts. I would say that if you have any questions on any of these issues, the MDU advice line is a resource which we would encourage you to use for any of these issues at any stage. And other than that, thank you for joining us.